All right, there we go. All right, well, welcome everyone. Thank you so much for joining our first meeting of the new year. Welcome to the Behavioral Health Advisory Group January 2024 meeting. Happy New Year to everyone. Hope the holidays went well and everyone is doing well in this cold weather. So thank you again for joining us today. In our time today, we're going to spend a few minutes opening up our meeting with some introductions and some warm welcomes to some new folks we have joining us today. In light of the new year, we figured it would be a good time to go ahead and kick off a discussion of our goals, objectives, and strategies and have a short brainstorm session around those topics. We will end as we usually do with our community announcements and upcoming meetings, and then we will adjourn for the day. So with that being said, if we have any new members or anyone who would like to come off of mute and introduce themselves, feel free to introduce yourself with your name, organization, and any milestone you may be celebrating in 2024.
I would love to jump in as this is my first meeting. My name is Xiomara Medina. Like I said in the chat, I am the Associate Director for Clinical Training at Bowie State University. So many of you may have worked with our interns and just, working on flooding the market with counselors of color who are culturally responsively trained. And a milestone I am celebrating is I just got accepted into the PhD for Counselor Education and Supervision at Bowie. So classes start on the 29th.
Congratulations.
Thank you.
Congratulations.
Wishing you a wonderful semester, and thank you so much for joining us. And if there are ever any announcements or any news that we can send out in our newsletter, please do feel free to send those our way. All right, anyone else who would like to introduce themselves for today? Anyone else celebrating any fun, new, exciting milestones coming up in 2024? Anyone else starting a PhD program or anything exciting? I'll certainly continue to use that chat function there to introduce yourself. We will go ahead and jump into our discussion of our goals, objectives, and strategies for today. So just to do a quick level set, and when we're talking about our goals, objectives, and strategies, just understanding how to differentiate the three. So just to go over briefly, we'll have our goals. Those will be the larger outcomes that we'll be working towards. Our objectives will be a step down. Those will be the measurable steps that we'll take to achieve our goals. And then the strategies that we'll discuss will be those approaches that we'll take to achieve the objectives, which will then in turn create our change towards our goals. So just wanted to do that quick level set. These will be the three tiers that we'll be discussing today and going over, and specifically looking to more of those strategies that we can go over as a group and see what we can start working towards in 2024. All right, so our first goal, our first BHAG goal, and again, this is all being informed by the community health assessment, as well as all of the work that the BHAG has been doing since for many years now, and has especially picked up in 2023 with looking towards all of its partnerships and this idea of creating a resource that houses all of the resources across Prince George's County for behavioral health. So our first goal is to promote upstream behavioral health care to prevent the onset of crises. So falling under this first goal is our objective. By December 2024, we'll support a robust behavioral health continuum of care with behavioral health resources across Prince George's County. Margaret, I'm going to tap on your shoulder for this one. If you have any context coming from TLC MD about some of the work that you've done with the crisis continuum and kind of giving some of that context as to this larger continuum of care.
Yeah, actually, we just had a conversation earlier today with one of our vendors that is part of the emergency crisis continuum, and this is really trying to help make sure everybody is aware of this entire crisis continuum, how to navigate, the residents to the next appropriate one. So no matter where they come into this continuum, we want to navigate them up or down based upon the level of intervention that they need. And then what can they expect for the next level? So we talked about, we had somebody that was called on our MRT team. They did their piece. They then transferred to the hospital. The hospital, again, we're meeting these building process protocols, and so that everybody knows when they are playing it with each other, not playing, but interacting with each other, what is the next step, and then telling the family what they can expect next. So, it's building this whole education along this continuum and letting them know at each step what each of the providers will be doing and then what will be expected next. So I think as we continue to build the emergency crisis continuum, we're working very carefully to educate each of the entities that are doing the warm handoffs to each other. But now we're learning that we also have to share with the family member or the person in crisis what they're doing at the time. When we do the warm handoff to the next person, what does that look like? And so that we're all in sync with each other and synergistically working together and constantly helping the person in crisis as well as the family know what is the next step so that they can be advocates for themselves as well.
Thank you for that, Margaret. So again, building off of that emergency crisis continuum of care and trying to look at those resources that exist before and after maybe someone enters that crisis continuum. And as
Taylor, I did want to just add one other thing, and I'd love for the committee or the group to figure out like what part they could play. Like we're utilizing educational components like rack cards or navigation pieces that we can put in the emergency room in clinics and to say call 988 or call MRT or go to the dire care center. Like we want to have the community also be aware of who they should call at least when, right? Like if they want somebody to come to them to call MRT, and we're saying that, if you need somebody to come to you, it's those kind of things that we're getting, and we can give them to the clinics, we can give them to the hospitals, we can give them to senior centers, we can give them to schools. So I'd love to have the group really think like, how could we get that kind of information out there? Those things are, then we'll hopefully have them at least starting at the level they think they are rather than going directly to the emergency room or going to the courts for an EP, those kind of things.
Are there any general reactions to what Margaret was just mentioning? I also have this next slide that involves a little bit more interaction from the group. That's a Jamboard activity of what folks' specific components that they're looking for in the continuum of care. And we can also incorporate what Margaret was just mentioning, where you see yourself fitting into the continuum of care, maybe offering some suggestions if you offer your organization's name and any ideas you may have in this Jamboard. And I can put this link in the chat.
Hi, Margaret. This is Denise.
Hi,
I would
Denise.
I would just suggest also places where people frequent, right? Like Chipotle, Starbucks, those places to have, maybe they'll allow you to put things in the window like a little sticker with the 988 number or, advertising the Diet Care Center.
Yeah, thank you, Denise. Yeah, those are the kind of things that we definitely want to do. And again, I think it takes a village, and we're all part of this village. So I'll be happy to try to figure out what do we want it to look like? Because they also can put it on little peg boards, but maybe if this group can figure out what should that be. We have something that I think we work with actually JB on about the emergency or the crisis continuum, where we had, 988, then we had MRT, we have the Dire Care Center, and we have Mindula. So we have sort of these 3 or 4 levels of care that they can, and it sort of talks a little bit about them, but maybe we could figure out what kind of document does that look like, and where should it go? Because maybe we've also talked about having a little business card. One side can be for 988, one side could be for MRT. So then people know, and it's just a little card that they can keep with them. And that's an easy thing to distribute everywhere. So, I would love to have those kind of ideas. So, and places, Denise, if you guys know those really high frequent places, let's get those together to put it on the jam board, and then we can say, here's places to put educational material. That would be wonderful.
Margaret, I was wondering with the MRT, I mean, one of the issues I know in Maryland is we have terribly long emergency room wait times. And I think that's because a lot of behavioral health clients are going to emergency rooms and then waiting for beds rather than getting MRT and maybe in-home stabilization. I was wondering if maybe the emergency rooms could kind of educate people who are coming back multiple times to use MRT. I, I don't know if they would see that MRT would see that as a burden, but it just removes people who from the emergency room who really don't need to be there.
Yeah, Larry, you're right on target. We just were talking about that with our MRT team, our data team, because, we're just looking at data, trying to figure out how do we get, this one is upstream, right, rather than going to the emergency room. And we've done a lot of work with UM-Cap region, really trying to get them to say, if they, here's, an MRT BHAG card, make sure they can get that before they come to the emergency room. But there's also some logistics of how do we, and then now that the Dire Care Center will be opening, hopefully MRT can take them over to the Dire Care Center. So that is ultimately our goal. And the EDs are very, very welcoming of that. I think what we were talking about is because we were just talking about even how do we get them to make that call before they go,
Yeah, I just noticed my father-in-law had to go to an emergency room last weekend, and again, they're getting really full with, people with COVID again, and it's just, I just think any less people who don't have to be there just makes it, just makes it easier for the emergency rooms to focus on, people with, very dire medical emergencies,
Yeah, we're working on that. And we were just talking about that with our mobile response team this morning, just about working with the emergency room and then having the emergency room really, give that card out in essence to say, next time, you can call MRT, they can come to, it's where it's really some of the sticky points is those EPs when, people are still needing to go, but then we were talking about then having issues of capacity to even admit. So then they're pretty much discharged, but So there's a lot that we need to work on with the emergency rooms, but I think we've started those conversations and we're building up the protocol and the processes to help them. And the MRT is very much a part of that solution.
Great, thank you.
Mhm.
Adding on to that piece, Larry and Margaret, I think that there's an opportunity for us to recruit some net promoters into this work. Carlos and I and others I know I see on the call were on a high utilizer call with the sheriff's office, either, I don't know if it was this morning or this afternoon anymore, but at some point earlier today. And they're working on similar questions, maybe more specific to individuals, to EPs. But I think there's an opportunity there for us to pull in and draw on our networks to create net promoters who are then advocating for the continuum that we've sort of laid out or figured out how we're communicating. And emergency rooms are one of them. They were also on that earlier call, a couple of representatives from hospitals in the county. So I think there's so many similar networks like that focused on really niche areas of this discussion where we can have a wide impact if we're able to not convince, but to draw in others to promote these services.
Mhm.
And also here on the Jamboard, folks, I didn't give much of a tutorial on here, but if you are seeing in the chat the link to join the Jamboard and then going in and adding a sticky note, you're able to capture your thoughts here. We had a few others to mention: giving info to school counselors to share with families and communities, empowering peers, high schools and colleges. Anyone who put those stickies, would you like to share more about that?
Yeah, so I put the sticky about having the school counselors have that information because families and communities have built really strong relationships with school counselors at all levels. And so they kind of trust them as mental health professionals, and they have such a wide reach to our families and communities. So any documentation about education, like I saw someone else say, the 988 cards and MRT information, um, making sure that that's available in schools because it has such a wide reach. And when we're talking about prevention, so I think the emergency room piece is huge, but that's kind of like when people are already there and either feeling in crisis or feeling like that crisis could occur. But on the prevention side, having people know where they can reach out to, I think the schools just have such a strong community building process that could be really helpful.
Thank you. And Winnie, did I see another hand? Did I see your hand up?
Yes, you did. Thank you. My excuse me, kind of going in, piggybacking on Zamira's comment about the giving the schools counselors sharing information. The whole school system. How do you penetrate that system? And does anybody know? And how can we do that as a part of this behavioral health continuum of care? Because the MRT goes to the schools, but we go to certain schools when there's a crisis and they're contacting us. It just seems like when we go to that school, we leave information, it stays at that school. We have provided the MRT commercial that TLC provided um, did to the school system. Audrey Sykes, Emily and another person, Darren. No, I probably got the name wrong. and we provided them those those videos as well, to in hopes that they would at least post them on sites that parents can log into their children's grades or whatever, and be able to see these resources. Um, but it seems like we're not making a great impact, not even with the 988 information, because we give all of that, but it's like we're making little itty bitty strides. So how do we make a greater impact in terms of sharing information?
I think Samara had her hand up.
Yeah, I would just say that the best way is to try and get into counselor in-service days and be a part of the agenda so that you're reaching all of the school counselors, as opposed to, like you said, just going to the school that you were called out to, but reaching out to the instructional specialists. And Doreen Hogans, who is the coordinator for school counseling for PG County, is probably the easiest way to get the most bang for your buck there and seeing the most people that you possibly can. They do go out by levels. Obviously, all the school counselors can't be out at the same time, but as the first in line mental health professional in the building, I think this is a really appropriate thing to have on an in-service agenda.
Yes, and we were scheduled to do that on January 22nd, but because of the school, what is it, snow days, they canceled. So I did let them know that we will be open to, you know, doing an in-service with, doing training with them on the in-service when they're available. But thank you, Zamara.
And we also had some additional notes left. One says communication about what to do when there's a behavioral health emergency and what to expect during the process. Another says helping behavioral health crisis organizations with data collection to support quality improvement and understand need and utilization. Would anyone who left those notes like to expand on those ideas?
Taylor, I did not write that, but I would like to let everybody know that, we are working on developing really like a behavioral health data dashboard, actually, that, I mean, right now it's including more of the emergency crisis continuum, but working very closely, with the health department and looking at that data dashboard. And as we bring on additional components to that continuum, we're making sure that we integrate the data that we need to really look at where the services are, who's using them, what kind of services. So hopefully, once we bring up the Dyer Care Center, we'll start to be able to show. Carlos and I were just meeting with our data team. They have and again, we have a lot of data from our MRT teams just showing like where they're going, where they're being dispatched, what kind of dispatched information, so that, everybody will be able to see, and sort of it helps the county make strategic decisions about where the services needed the most, where are the gaps. So we're working very diligently on getting data sets, and, we're hoping once, with the other providers, once we do the referrals out, that we can also sort of see that full continuum and like the outcomes as well. Not only data sets of like, how many people, what are the ages, what's the gender, what's the disposition, and all, and where is it happening, but our goal is to longitudinally look at a call that came in from 911, 988, MRT, wherever they came in, to really see how long did it take us to answer them, how long did it take us to get service to them, where were they navigated next? because we want to develop a very comprehensive system and include everybody who can be of help in navigating, the residents to the appropriate level, and then of the intervention they need at the time, but then ultimately getting them in the right care, So we do have that data. So I wanted to share. I'm really excited that I'm hoping, we'll be able to show you maybe some maps and data sets that we'll be getting once we get the Dyer Care Center open as well. And because we're learning, I think we're way ahead of most people in the state as far as doing those warm handoffs from 911 to 988 to 988 to MRT. So it's really the county needs, and everybody involved needs to be very proud of where we are with that and just doing these little tweaks. So that's coming.
And Margaret, I'm going to circle back to one of your original questions, and that was asking some of our members who are on the call what it would take for them to be on this continuum, to be included within this continuum. What would you all like to see? Like, what are the important components of this continuum of care, and where do you see yourself or your organization plugging into this continuum, and what does that look like, and how does that feel like for you all?
Taylor, I hear a lot that we're wanting to focus more on pre-crisis. And so maybe that's a primer too. How do you plug into this continuum, especially within the lens of pre-crisis?
And I also think with that, Nina, I think it could also be, it's like almost can be a circle, right? Right after they go through a crisis, navigating, getting them stabilized, and then how do we connect them to support? So if there's support groups, there's, so I think it can just, start at any point. They once they're in it, you navigate them appropriately, but then once they're stable, how do we keep them from re-entering? So that's maybe another way to look at it as well. And I think that would be sort of the next thing we're looking at is like what kind of support groups do we have? Where are they? And do we need, what else do we need, to help that in and to have it not happen again? But then there's also the beginning where shouldn't, how do we prevent it? And it's probably going to be, I know there's the consortium that's really trying to deal with that, because it's with how do we get ahead of any of this with our kids, right? And doing that screening as part of a wellness exam. I think that's what, was behavioral health wellness. I think we talked about that last month, which, I think is something that I know there's legislation, so I'm hoping we can not forget about that and try to get that pushed through, that we have sort of like that annual behavioral wellness exam as well.
While gears are turning, I just want to respond to Charisse and Tim Jansen in the chat. The idea of a triage staffer in emergency departments. And that's something we've talked about before in a number of different ways. Margaret, I like your naming a concierge, a behavioral health concierge. It's sort of the same idea. And I think we have opportunities to explore mental health diversion clinician. As Charisse has noted, it's difficult to penetrate the hospital systems, but with Margaret and Carlos leading the charge there, we've had some some more successes recently. So I do think that's something we can flesh out, and would welcome comments and suggestions on that idea specifically. It's a little bit more hospital focused than, maybe the full continuum. Is there a way we can extrapolate that to the concierge idea so that it covers the full continuum?
I think the other thing we were looking at and still trying to figure out is having the peers be part of the ED as well, having somebody there that can really, especially if they go in and get evaluated and get discharged, but they're still not really okay, but they're better. And they're not, maybe at a level to be EP, but then how do we engage a peer to at least help them? So that's something else we're looking at, trying to figure out how do we utilize the peers. I know I was speaking with Winnie earlier this morning, just trying to figure out, there are some reimbursements for peer peer services. So we're trying to figure out how do we capitalize on that and maybe have the ability to have them interact or interface with the emergency room or case management at the hospital. So, there are opportunities that we're looking at. So I'm glad everybody's sort of, we're really honing in. So thank you for that.
Yeah, I just wanted to say, if you don't know, NIMH is actually having a conference, an online conference on peers and suicide prevention. And I think particularly because of the workforce shortage, that the need to utilize peers more, because so many organizations are having difficulty recruiting clinicians. So I think peers are going to be kind of a new area of focus now.
Yeah, I relate them to sort of the community health workers that do a lot of work on the somatic side. I think they're and again, the community health workers are amazing to really help navigate and advocate for the client or the participant. So I do think, Larry, I agree with you. That's going to be another area that's going to, try to start probably expanding quite a bit. And I wouldn't even doubt it. And I know they already have a certification course, don't they, Nina? Aren't you guys doing that?
We do offer a certification curriculum to become a certified peer recovery specialist. The state also requires 500 hours of paid or volunteer peer experience to become a certified peer, but that is a new program through the county. The curriculum piece, not necessarily the 500 hours.
Any other thoughts on this resource for pre-crisis? Just curious, just throwing out the question of what resources do exist? What are folks using in the county as it stands? Are there online resources or resources that you are aware of that folks can access pre-crisis? Or as JB had mentioned in the chat, that pre, during, and after, is there any sort of resource that folks are aware of?
This is JB. I mentioned the pre, during, and after as a way to organize the data. But also I wanted to add, and I just put it in the chat, that, there was some work that was done on the sequential intercept model map for Prince George's County that does deal with some behavioral health continuum of care aspects. You might want to look through that.
Thank you for that. So hearing that this is a gap, what would folks hope to see? What are folks, do you have any suggestions for what would need to be seen pre, during, and after crisis for this continuum? Or are there any suggestions that you have in thinking through what might this look like? How may it be accessed? Or any thoughts? Any thoughts there, knowing the clientele that you serve or knowing the services that you provide?
This is JB again. Question: are we aware, or do we have information on the behavioral health continuum of care in surrounding counties that is successful, that we can look at and pull from, that are already established and moving forward?
I will just say I have seen just the emergency crisis, but Margaret?
Yeah, I think, with this new crisis now model, right? That's what we're trying to implement. I think it's one, I think if we're talking about in the state, but I know Arizona, and Carlos, you may be able to speak more to this. They probably have, they've been doing crisis for a while, and they have, their officers are very integrated and everything. So, but I think in the state of Maryland, that has not been determined yet. But in other states, I think they do. I don't know if you'd like to add anything, Carlos.
Yeah, Margaret, and great point, JB. And like Margaret said, I think Prince George's County, with the great work that our 988 CCSI and our MRT, our mind team is doing, is really blazing the trail for the state of Maryland. And based upon the data collection that we have with the crisis continuum, and like Margaret said, adding the crisis now, which is the gold standard crisis stabilization facility, we are in the top tier of what's happening in the state of Maryland. So what we're doing now, Winnie and I have actually been looking at some work that they are doing in Arizona and kind of piggybacking off of them, which Arizona has been one of the founders when it comes to crisis care across the country historically. So we've really been leaning on what they're doing in regards to their MRT services, in addition to crisis stabilization, as we know, RI International as our vendor for the stabilization. So really looking at what places we can kind of tailor ourselves off of outside of the state of Maryland, to just make sure that what we're doing stays on course to keeping us, um, you know, um, you know, operating to the best of our capabilities within the state.
And I'll just, oh, go ahead. I was just going to add that the national model through SAMHSA, and I think they tweaked the language a little bit, is someone to call, someone to respond, and somewhere to go. So I do think we have addressed these categories in our continuum of care. And now it's about that promotion and how are we establishing the continuum that is developed here within our various community connections. And then how are we also going a step, I was going to say a step above, but a step before, to address the pre-crisis. I think that I would agree with Carlos that we're in the forefront of crisis work with having the established model, and then considering what else can we do with drawing in peers, with thinking about pre-crisis. So there is a model, and I think we're falling well into it, as well as expanding upon it.
I was going to say, I think these kind of meetings where we're communicating what the needs are, what we're doing, and then making sure everybody sort of understands, who's doing what, where, and when, and we know how to all synergistically work together and navigate and say the same messaging. It has been amazing, you know, working with our vendors in the emergency crisis services, you know, just opening up those lines of communication, finding where sometimes you just have to find out where that little breakdown is, you know, but then fixing it. And then it's amazing from a year ago where we are today, I think is just amazing. And it's through the collaborative nature of all of the organization and agencies that are involved in the emergency crisis continuum. So I think, JB, you know, I think, you know, Prince George's County, like, you know, is way ahead as far as this continuum. And now we're just bringing in the other building blocks that are like, and Nina was saying, like, how do we do this pre-crisis in education and destigmatization and those types of things? I think is where we have some of the components. It's just how do we get them out there and promoted in the sequence.
So what I understand is we have a behavioral health continuum of care, well, especially for crisis response. But what we're trying to do now is figure out where the gaps are.
I think we're doing that along the way, but we're also trying to, we have that the crisis piece, but we're trying to get the piece before crisis and then the piece after crisis, so that we have that full continuum from, you know, preventing all the way to self-management, I guess is the best way to say it.
Thank
I'm going to switch us back over to our slides here. I think this was really great to guide us into some of the strategies that it will take to complete this objective of building this more of this pre and after crisis model. So let me share from this slide. So here were some of our identified strategies. So by 2023, conduct a BHAG partner survey to capture the services and population served among BHAG providers and community organizations. We completed this in the fall of last year. You may have remember completing the survey about your organization and your population served and services provided. If anyone did not fill that survey out and would like to, I can send the link. Just let me know in the chat if you need that. Another strategy to work towards this objective includes, by May 2024, develop 12 collaborative partnerships to share organizational information and initiatives during monthly convenings. So this should hopefully be ringing many bells. All of our presentations that we do monthly is working towards this goal of increasing information sharing across Prince George's County, and just making sure that everyone on these calls are aware of all the different resources and all the robust care services that exist within the county. And then another strategy that we have listed by November 2024, identify gaps in behavioral health care and prevention efforts through a population health lens, identify at least 3 collaborative opportunities to address care gaps. As JB and Margaret were just mentioning, throughout this process, we will certainly identify gaps in care. And so when we're looking outside of this crisis model, if we can look to the pre and the self-management stages, trying to see where those gaps in care lie and trying to create a plan to fill those gaps. So that has to do with our first big goal of promotion of upstream behavioral health care. Do we have any reactions to any of the strategies or any suggestions for any strategies to add? All right, and I will send out these slides after the meeting, and the Jamboard will still be accessible after the meeting. So if you have anything to add, please do. And then another one of our objectives that falls under this goal of promoting upstream behavioral health care has to do with engagement with state initiatives to expand access to comprehensive health services for adolescents. So we are in the midst of completing this goal, this objective and this goal by the facilitation of 2 meetings with representatives from the Maryland Consortium on Coordinated Community Supports. So you may remember back in October, I believe, we had some representatives from the Maryland Department of Health come and talk about the RFP and that opportunity to engage with the consortium. We will continue to let you all know information about the consortium to work towards this goal, but we really want to make sure that we're pushing out information for you all to become involved with this hub and spokes model, especially as it has to do with behavioral health services for adolescents. And so that's our strategy 1.2.2 that we're working towards, is the dissemination of information from the consortium. And then our second goal has to do with the integration of programs and services in the continuum of care for high-risk individuals and their social support networks. So our objective for achieving this goal is by July 2025, identify and engage Prince George's County resources and stakeholders from the criminal justice system to disseminate and improve access to resources and services. And our 2 strategies to complete this objective include, by December 2023, conduct a BHAG partner survey to capture the services and population served among BHAG providers and community organizations. Again, we successfully completed this by the end of 2023, and we are able to complete strategy 2.1.2 with the findings of this partner survey. So strategy 2.1.2 is, by March 2024, develop 3 collaborative partnerships with representatives from the criminal justice system to share organizational information and initiatives during monthly convenings. We are well on our way of accomplishing this strategy through our partnerships with the criminal justice system in Prince George's County, and we will continue to invite more representatives to our monthly calls. So if anyone has any of their networks that they believe need to be at the table, please do forward them the BHAG invite and let me know how we can get those individuals to the table. Any reactions to this second goal, the objective, or the strategies?
Oh, no, I was just going to say, I serve on the consortium and just wanted to give you an update that people should be hearing in the next week about their budgets, and the final award should be in the last week of this month. So people are going to be getting some good news soon. So.
Well, and I'd just like to add, Larry, and please correct me if I'm wrong, but I think Prince George's County had a very strong showing with the number of spokes and people that were collaborating. So I thought I attended that one meeting and just thought that was amazing. And it goes to show the level and the engagement of everybody in the county. So I don't know if you had anything else to add.
Yeah, that was really interesting. I thought, yeah, Prince George's County had the most proposals of any county in Maryland. It was really impressive, the response of the provider community and interest to providing services. I think that's a big credit to all of you. There's not any other county that had that kind of response.
And Sharice, you had your hand up?
I did. Good afternoon again, everyone. Yes, Larry, we had 55 respondents for that. And I think our community partners getting the word out about it, sharing the information. We did a lot of outreach, and I think the outreach definitely helped with the responses that we received. There was a lot of technical assistance that occurred, just being very responsive to those who were seeking information or guidance of who to get letters of support to. So just wanted to thank all of those partners, and some of you on the call who just helped get the information out to the public. So we're hoping that with those who were selected out of the 55, that those programs will definitely assist us with some of our goals here. Number one, and providing those support services to our children and adolescents in the county. We're looking forward to it, excited, actually.
Yeah. And Sharice and Larry, I think a lot of that is kind of what we were talking about earlier as well, with Prince George's County leading the charge for the state of Maryland, and essentially putting ourselves in a position to be national leaders in this space as we continue to grow stronger. So I think everyone should be proud of that.
I agree. Thanks, Carlos.
Wonderful announcements to start off the new year. All right. All right. And so all of that excitement leads us to our last and final goal, that has to do with the destigmatization of the utilization of behavioral health services. So we understand that with the continuum of care, we're looking to really promote those upstream factors that will create that systematic change. But we also recognize that at the individual and the interpersonal level, we need to look to fostering change and seeing how we can get more utilization in behavioral health services. And for all of those who were able to attend our December meeting, you heard from Dr. Blunt about SB 108 and funding behavioral health screenings during annual health visits. So this objective coincides with some of that work. By July 2025, advocate for behavioral health screenings for physical and somatic care practitioners to use during annual wellness visit with patients. So again, this is our larger goal that we're going to be working towards. And to strategize this objective, we have by January 2025, collect baseline data on behavioral health screenings during annual wellness exams. This includes baseline data on screening tools that are currently used in the field, as well as testing frequency. We'll also be curious if any legislation is passed, how that may impact some of these baseline numbers that we see. The next strategy includes, by February 2025, conduct an environmental scan of evidence-based screening tools to see what is used already, what is used in other states, and to see, again, what has that evidence-based backing. Our next strategy is by March 2025, identify screening tools for BHAG members to promote. And lastly, by June 2025, develop messaging for partners to promote to primary care providers. So again, this entails being able to find and advocate for screening tools that would be used during annual wellness visits with patients. So a larger goal that has to do, again, with destigmatizing utilization of behavioral health services through integration in primary care visits. And I know that's a lot that I just threw at you. So do we have any questions or any reactions to this goal?
Sorry, I have so many reactions today. I just want to say that this would be another group of people who should know about mobile crisis response, because I saw a study of why many primary care physicians don't do these screenings, and it's because they feel when they find out someone has a mental health issue, it's very labor intensive. But if they know about mobile crisis, they might be more likely to screen for people. So just another group that could get those stickers or cards about mobile crisis.
And I think, Larry, and the 988 as well, if we can get that information to primary care offices or individuals who provide any type of somatic care, because 988 sometimes is that first, I don't know the correct verbiage, but that first contact when someone is experiencing some type of crisis or feels as though they are, or thinks that a relative may be experiencing something. And so there's so many other resources for someone that's not in an active crisis per se, maybe not in a Margaret probably has better words, but not an active crisis. So I think 988 would be a good resource as well to promote in that group. And actually, Tim was on the call. I don't know if Tim or Letitia is still on the call. Can speak better towards what they would do. You're still there, Tim?
Yeah. What's the question?
We were talking about those somatic health practitioners, primary care offices, just having the resources once they do screenings. Then what? If they find out someone is in need of some other type of support, what happens? And Larry had mentioned, the share MRT resource, and I was sharing that we should also share 988 as well.
Yep. Yeah, 988 can do a couple of things. It can do some of the pre-crisis stuff to keep things from bubbling up, and then it can also provide ongoing resources so that people can stabilize or meet the needs. It can also then, work up to where, if they need to be connected urgently or critically, they can do that as well. So the more people that have the information, the better. The earlier they have it, the better. It's always easier to help on the front end than the middle of it or the back end.
Yep, thank you, Tim. See, he said it better than I did.
I did not.
Absolutely. I am noting that on the side here and making note for, as we look towards working towards these strategies, these are the conversations that we need to have of, what do physicians need to be informed of? How can they be informed of it? So thank you for that. Any other reactions or comments to this goal in particular, or any of the goals or objectives or strategies that were mentioned today? All right. Well, I will send out these slides again. If you have any points that you would like to add to this Jamboard, this was another Jamboard that I made that has to do with some of the strategies to work towards this goal and objective. So if you have anything that you would like to add after the meeting, feel free to utilize this Jamboard, and we will certainly be coming back to all of this information. So feel free to add anything that you have. All right, and we are just going to go ahead and jump into community announcements, but I want to first thank you all for getting through all of those planning discussions. We just want to make sure that we are starting off 2024 grounded and guided by all of our goals and objectives that we hope to accomplish throughout the year and so on. So thank you all again for participating in that, giving us feedback. All of this information will always be available to you. And if you have any other reactions after the call, please do let us know. We are happy to bring things back to the group as needed and continue this discussion. So thank you all again for participating in that. All right, so we'll just go ahead and jump into community announcements. So Kim, if you are on the line with us.
Hi, yes, thank you, Taylor. We just wanted to share a couple of announcements. This first one is from the state side. So if everyone didn't already know, starting January 1st, Medicaid is expanding gender affirming healthcare services. I think this is important for us to share within this group because access to care is certainly important for people's mental health and well-being as a whole. So we wanted to spread the news of these updates, and I will go ahead and put a link in the chat so that anyone can follow up with those updated services that are available through Medicaid. And Taylor, you can go to the next slide. And then this is an event through the health department. So this is a status neutral summit taking place on January 31st. That'll highlight first person strategies to diagnose, treat, prevent, and respond to HIV. So we do encourage anyone that's interested to register. I can also put a link to this event for registration in the chat.
All right. Thank you so much, Kim.
Thank you.
All right. And then our next update, Larry, you were reading my mind earlier, giving that consortium update. So the consortium did have a meeting on January 4th. If you were anything like me and hadn't turned on your brain just yet in the new year, the recording is available. The Zoom recording is available. I can put that link in the chat and just note that this is the passcode to be able to access that meeting. Here was their agenda of the things that they went over. Again, they included a lot of highlights of the great work that's going on across the state, and then also gave an update on the hub pilots and that RFP. So we will be joined in some future meetings by the LBHA, who will be able to give more update on the hub as it relates to Prince George's County. But if you are curious about any updates, feel free to watch this recording here. Let me see if I can access that in the chat real quick. All right, and then our next updates for you all. So we wanted to share out some updates from 211. These are some really great resources for everyone who was able to come to our quarterly meeting and hear from the speaker. We wanted to make sure that you all had access to this website and were aware of some of these care coordination services and opportunities to engage. So this has to do with some referral programs. You can access their website here and you'll be able to see all of these resources that are available. Another really interesting resource that's available on 211's website is Maryland's Bed Board, where you can actually see all of the psychiatric and crisis beds in real time and their availability, all broken down by hospital. So it's a very unique resource. I was actually using it today just to look around, and it is really amazing to see this resource come to fruition. And then also some more opportunities to become engaged. This 211 hospital network. If you wish to join the network, again, I will put the website here in the chat that you can interact with, and any consultation services to get engaged with 211. All right, and I will open up the floor. Did anyone have any other updates that they would like to give, or any community events or announcements? All righty. Well, thank you all so very much for your participation today. Yes, we had one here from Alicia that says, QCI Behavioral Health is accepting new patients. And we just put in the website there. And if there are no additional announcements, we will see you all back in February. On February 21st, we will have our next monthly BHAG meeting from our usual time of 3 to 4:15 p.m. Continue to let us know if there's anything else that you need. I will be sure to send out these meeting slides in the meeting recording. And again, do let us know if you have any other insights on our goals, objectives, and strategies.
Thank you, Taylor.
Thank you, Taylor.
Thank you,
Thanks,
everyone.
Taylor.
Bye-bye.
Bye, everyone.
Bye, everyone.